Michael, welcome. So we are very glad to have you this afternoon. Let me first introduce you. You, you are a Professor Emeritus of Medical Oncology. You retired maybe 3 years ago?
Close to 5 years ago.
5 years ago. You are a graduate of Washington University St. Louis School of Medicine. That was in '72. And you have your internship and residency at Southwestern Medical School program in Texas, between '73 and '74.
Yes.
And you have done your fellowship at Brigham and Women Hospital, Massachusetts General Hospital, and at Dana-Farber Cancer Institute, 78. And
Yes.
you have also a grant from National Institute of Health, 76. And you are a fellow of American Society of Clinical Oncology. You won Statesman Award of American Society of Clinical Oncology, and you are a fellow of American College of Physicians. You published hundreds of articles, and you trained resident and fellow from US and from around the world, hundreds of them. And you are a professor of medicine since 1978. Your special interest is medical oncology and especially genitourinary malignancies. You hold a blog, Prostate blog. We'll talk about it later at the end of this interview. We have some things to clarify. And you are a member of the American Association of Cancer Research. You are a fellow of American College of Physicians. You are a member of American Society of Clinical Oncology, ASCO. That's very impressive, Michael.
Well,
there is one thing you didn't do. I guess you didn't invent the internet. You know, someone pretended to have done that. But you actively participate in the creation and the maintenance of the ASCO website. Which
I helped ASCO get online, which was kind of fun.
This site which provides access to a wider variety of clinical trials for patients on urologic oncology cancers. Michael, welcome to Bridging Science, and it's a pleasure to have you this afternoon. After all these years, you look still very great.
So, you're very kind.
Welcome, very welcome, Michael. So how did you get in this chosen field? And did any one of your mentors have any impact on your career?
So I had several great mentors. In medical school, there was a guy named Stuart Kornfeld, and I did research in his lab. And he went on to become very famous member of the National Academy of Sciences, worked on glycoproteins on the cell surface. But that was my first basic science research experience. And then at Dallas at Parkland Hospital, the internal medicine chairman was a guy named Donald Selden, who just died about 2 or 3 years ago. And he was an unbelievable mentor, really a fabulous teacher. And everybody who ever came in contact with him at that training program was in love with him. He was such a role model for teaching. And then at the NIH, a fellow named David Rosenstreich was my mentor, and I did 2 years of immunology research. And then at the Dana-Farber Cancer Center, a guy named David Livingston, who just won the Klaus Award for the AACR a couple years ago. David worked the BRCA gene mechanism, among other things. And one of his mentees that followed me by several years, actually, younger guy, just won the Nobel Prize 3 or 4 years ago. Really a fine individual. So I was not one of the superstar trainees of Dr. Livingston. But there were people around that environment who were fabulous.
Great. Michael, a question was imposed on us by the current events, especially this pandemic. We learned from biology and emergency medicine that each time The body overreacts to an intruder. You're an immunologist, you know that. It harmed
Yeah.
itself before anything else. So in the current context with pandemic and the lockdown, patients of other diagnoses than COVID-19 are having their treatment and diagnosis denied or at least delayed. Are we overreacting? Don't you think that health problems that will arise from economic and social fallout of this pandemic in employment and poverty may be far worse than the virus itself? And what's the way out? Where are we going?
Well, as you probably know, you watch CNN, I presume, like I do, and this is a hot debate with a lot of political ramifications in the United States. I think that my impression is that the EU in particular has done a better job of kind of balancing the issues of opening too early versus the economic impact of staying closed is horrible and very tough decisions. I feel sorry for the political people who have to make these decisions. On the other hand, the science of the virus will not change. The infection ratio, if you can't get it under 1, you will have a continuing pandemic until we develop some sort of herd immunity. And I think herd immunity realistically is only going to occur with a vaccine. I think if it only occurs because we don't develop a vaccine, just getting infected, even though 80% of people are not that sick, the 20% of people who are sick and anywhere between 2 and 5% of people that die, depending on what statistics you look at, is a horrible price to pay. And I think the U.S. has done a bad job. I think we have had a very fragmented response. The central government has the states, and each state is controlled by one party, and there's, they tend to favor the science on one side or versus the economics on the other side, and it's a very hodgepodge here. I think the EU has done a better job myself, and I don't know what Africa has done, but Africa's had a lot more experience in dealing with pandemics.
And all this kind of
So we'll see.
If a vaccine to be developed, do we have any idea how it will work? Is it going to be like the old stuff with attenuated virus, or the virus made by or antigen made from the capsid of the virus, or it's going to be a new generation of vaccine? Something like the CRISPR, maybe something that work this way, but we'll talk about later, this technology of gene editing. And
so I think the vaccine question is a huge question. And I've been on several, just listening to several of the different podcasts and that sort of thing. And Anthony Fauci, who's the U.S. Director of Infectious Disease at the NIH, expressed some optimism yesterday that by the first part of 2021 we might have something. But if you look at realistically, we'd all love to see it work and be safe and effective and all that. And then you stop and think, well, how long did it take? We still don't have an effective HIV vaccine.
Yeah, sure. After 40
widely
years.
spread. And with influenza, we have to have a new vaccine each year.
Every year, yeah.
And we don't really know the mutation rate of this virus and whether it's going to turn out that the spike protein mutates that fast. So there's just a lot of unknowns. And then, as you mentioned earlier, the issue of a vaccine actually triggering an over response. So let's say you've had a asymptomatic infection 6 months ago, and now you get vaccinated, it might trigger a devastating immune response. So there's just so many unknowns. I think it's really challenging.
Great, Mark. Let's move on to your special interest, which is genitourinary oncology. What is the current position on screening on oncology, in particular for prostate cancer? There is an article published in the JAMA in last January who had some conclusion. I'll let you comment on that, on the article of JAMA.
Well, I think that the main issue that is, the big issue is trying to continue effective screening for the people who need it. And that's, there are all kinds of articles written about that. I think there's some hope that the use of the molecular markers in the urine and some blood markers and so forth that might be better than PSA. And now in the US at least, and I think in Europe as well, the use of MRIs to enhance the ability, again, to pick up the PIRADS 4 and 5 lesions and even some 3s and so forth. So my view is that we over-tested, starting with the PSA test in around 1990.
Mm-hmm.
The result was a huge increase in the number of cases and a lot of morbidity to patients who probably didn't need to be treated.
Over-treatment.
And then pulling back from that, we may have pulled back too far.
Yes.
And we missed some cases that were going to go on to be treated. And then, in the last decade or so, I think the increasing use of active surveillance and sparing some patients the morbidity of treatment with either radiation or surgery has been there. But we're now picking up more patients who when you pull back too far, then you end up with more patients who are present with advanced disease. So it's almost like the virus issue we were talking about. How do you weigh one versus the other? If you have to treat 100 patients to save one life, that's a lot of morbidity. If you get it down to treating 10 patients to save one life, then it's a better discussion.
Yeah.
And there's no treatment that doesn't have morbidity. That's the challenge.
Sure. You have written about the Movember movement in your blog. Tell us about this concept who started originally in Australia and moved and spread quickly to the rest of the world. Are you a partisan to this movement? Do you grow up a mustache?
I don't have one now like you do, but yes. Well, as probably some of the people who watch this video know, Movember sort of started with, I think, 3 guys in a bar. And I think maybe one of them had a father. I think Adam had a father who had prostate cancer or something. And they really said, what can we do to change this? And they started the idea of growing a mustache. And then same as people grow or do run a marathon on behalf of raising some money, or they swim a mile and get their friends to support them. The idea was to get your friends and family to help you, or to pay for your mustache, if you will.
Yeah.
And it grew from, I think, the early 2000s into an international movement. And they are now successful. I think their fundraising has been in the range of $100 million a year globally. They're mostly in English-speaking countries, and they tend to support research in the countries where the money is raised. And so both, the biggest places are Australia, United States, Canada, Ireland, UK, and a couple of other, New Zealand. And they've done a fabulous job, in my opinion, of supporting both research and support for patients. So there's a lot of ongoing efforts to create some online support tools that men who might be in a rural area who don't have access to, social workers and rehab people could actually get online support. But on the research side, they teamed up with the Prostate Cancer Foundation, and they've been absolutely critical in supporting things. So in the US, we have the Susan G. Komen for the Cure movement with breast cancer that really started, I think probably in the 1980s or early 90s. And that's been very successful at raising funds for breast cancer research. And I think for prostate cancer, Movember has been our equivalent. I used to say before Movember, I used to say Komen Komen has race for the cure and we crawl for the cure. But Movember has helped us, I think, pick up our game and have a lot more awareness of prostate cancer and a lot more support for both clinical and basic research.
Are they concentrating only on prostate cancer, or they are touching?
No, they branched out to men's health in general. So they moved from prostate cancer to also testis cancer. And then after that to suicide prevention. So they've got a broad portfolio
outside
now
oncology.
of projects for men's health in general,
Yeah.
including, by the way, a thing that I've become a lot more aware of and talk to my patients about, and I think all of us who are physicians need to do this. There's just such great evidence for exercise for everything, heart disease and so forth. But you look at any cancer and do these analyses of whether people are exercising or not. Many times exercise is as effective as some of the new drugs that are developed. But exercise is hard. You can't take a pill. You can't take a pill. So I now spend 5 minutes with every patient I see and review their exercise program and talk to them about how much intensity they need. 55 minutes, 3 times a week, mixture of cardio and resistance training. And I have become a devotee of that. I do it myself, and I'm absolutely convinced that we need to spend more time with our patients talking, along with, cessation of smoking healthy diet and all that. But I think exercise is underemphasized by us physicians.
Sure. My next question will start with a quotation of Will Rogers, who said that when Okies left Oklahoma and moved to California, they raised average intelligence in both states. This was attributed to the humorist Will Rogers. And to what extent this phenomena, which is called now Will Rogers phenomena, is true, and how does it apply to prostate cancer stage migration?
Well, yeah. It's an absolutely great question, and as you know, it brings the issue for scan techniques, and in particular, the fluciclovine test called Axiom here is more sensitive for soft tissue than anything we've had in the past. But even better, and now widespread in Europe and still not approved in the U.S., but available in some of the research institutions, is the PSMA-based tests. And so the PSMA ligands, there are 2 or 3 different ligands and then 2 or 3 different isotopes that are hooked to those. It's very sensitive. So you take high-risk patients, depending on however you define high risk, but typically, PSA over 20 or Gleason 8 or 9 tumor, grade group 4, whatever. And if you do those scans now, you find patients that with routine scanning are negative and you think they have localized disease, but with a PSMA scan up to a third, maybe even in some case series up to a half, will have metastases, lymph nodes and or bone metastases outside the pelvis. So when you get rid of those patients in any kind of a clinical trial, so let's say there's a clinical trial from 2010 with quotes, high-risk prostate cancer patients, and there's an intervention. For example, the PUNCH trial that was run by Jim Eastham out of Sloan Kettering. You had to have negative scans, routine scans, and then the patients were randomized to get 6 cycles of chemotherapy plus hormone treatment as part of their surgery overall treatment. So that trial hasn't been completed totally yet in terms of follow-up, but it did show some evidence of decreasing the number of biochemical relapse and no effect on overall survival, at least initially. Anyway, if you throw out the bad actors in that trial, suddenly things are going to look better. So if there's now a trial that's launched and you're using PSMA scanning, no longer are those patients who were negative in that trial being included in the new trial. So the new trial will look better because you've gotten rid of some of the bad actors. So that's the Will Rogers phenomenon. And it's going to be very important to keep that in mind as we go forward because of these new scans.
Right. The old concept of metastases in general was, which was one way from the primary to the secondary sites, now has been challenged, and tumor cells are ping-ponging back and forth between metastases and the primary, and sometimes between different sites. Could you please explain this phenomenon a little bit further, and what's the implication of therapy?
So it's a really great concept that you brought up, and I you know, there's an article in Nature from about 5 years ago. Once you could do a fingerprint, let's call it, of the tumors and look at different gene mutations, and prostate cancer patients have on an average, I think around at presentation around 20 genes that are mutated. So you can have a very nice fingerprint of a patient's primary tumor. And then if you do a warm autopsy, as they did in the Nature paper, and I think it was Hopkins and maybe one of the European centers combined data. But anyway, you could look at a lymph node, a bone metastasis, and so forth. And what they discovered was that the primary tumor might have 2 or 3 different spots within the primary tumor with different footprints, and a foot or fingerprints. And a fingerprint from one area might be the area that went to the lymph node in the supraclavicular area. And then lo and behold, if you followed that and said, well, where else in the body was there a single, you know, similar fingerprint? Turned out that a bone metastasis in the left rib might have that same fingerprint that was not present in the primary, but occurred after the lymph node.
Migration.
And then, as you pointed out, even migration from a bone metastasis back to the prostate. So it brought up a very old, it's a molecular proof of a very old concept in cancer medicine of the seed in the soil. So obviously the prostate is a good soil for developing a tumor. That's where it developed in the first place. And then that led or leads to the idea of, well, what if you took out the primary? Could it help? Because you've removed a lot of soil. And as you know, there's some evidence now that in patients, even with metastatic disease, there may be some benefit of removing the prostate, either with radiation or surgery, and getting rid of a large bed of soil, if you will.
Yeah.
I think it's still somewhat controversial. We get back into the issue of is the morbidity of treating the prostate in patients who have metastases really worth it? Interesting questions, but I think we're going to get better and better at figuring that out. And then the whole concept of oligometastases. What if you just what if you can radiate 3 or 4 of them? Does that help? And that's another part of this.
Is it oligometastasis? Is not considered a new separate entity, which should be considered a separate
it's
entity?
Certainly, as you know, certainly being written about. There are many trials ongoing in patients with 5 or fewer metastases. I think there have been a few German trials published, and some other ones saying that perhaps if you treat those metastases, you can delay the time until patients go on hormone therapy. It's not clear to me whether we are kidding ourselves. I don't know how many patients can really be cured that way, but there are some patients who have 1 or 2 metastases that probably can be treated and they can be cured. Of course, you get into the issue of how do you define cure, and in general, and prostate cancer is a disease of older men. And if they die of a heart attack, we call that a cure. So.
Michael, I know that immunology is an integral part of your training and interest. Immunotherapy tries to harness something new the human body has naturally within itself, and amplifying and redirect it against foreign invader and domestic enemy as well, particularly malignant tumor. This principle is not new in the treatment of cancer, and one of the most successful story in cancer treatment is the use of BCG in non-muscle invasive bladder cancer. We will talk about the new therapy that has been developed, and we'll talk successively about dendritic cell vaccine, immune checkpoint blockade, and bispecific T cell engager, and targeted monoclonal antibody, and genome editing. To start with the dendritic cell, now it's more than 5 decades, immunologists knew that the optimal antibody production required collaboration between B and T cells, and they knew that the third cell, which is the plastic adherent cell, which is the dendritic cell, is necessary to initiate the antibody response. Study performed over the last 40 years result in the characterization of dendritic cell as the primary antigen present in cell for the induction of adaptive immune response. So the spilocell was T, which is developed this way by training somehow the dendritic cell to produce these antibody directed against prostate cancer cell. What is the current indication of spilocell T, actually, and how what's left for spilocell T once these new hormonal treatment are introduced and are competing now with the spilocell T as they are moving earlier into the treatment of prostatic, especially castrate-resistant prostate cancer?
Yeah, so spilocell T was long time in development, and essentially patients donate their own peripheral blood mononuclear cells. The cells are shipped off to a factory, if you will, and incubated with an antigen. It's prostate acid phosphatase, a version of that, and then some cytokines, and then the activated immune cells, which mostly, as you're talking about, the the dendritic cells, are then transfused back into the patient as a vaccine type thing. It was the first really approved vaccine for any cancer, and it's been over 10 years now, approved for patients with castrate-resistant prostate cancer. Moving it earlier has been challenging, but it's in the same way that any new therapy is challenging for prostate cancer, because if you are using the best endpoint we have in cancer medicine, which is survival, prostate cancer is a very slow disease. So if you develop a new therapy, it may take 10, 20 years before you reach an endpoint, enough patients who've died of either prostate cancer or something else to get a readout. But CIP-T was approved. In looking at subgroups, it was patients with lower tumor burden that benefited the most. The overall survival advantage was measured in the range, I think it was 4 to 7 months or something. But if you looked at patients with PSAs less than 20, it was 14 months or something similar. But it's complicated, right? Because every patient has to donate their blood, and it's an individualized vaccine. So that makes it challenging. And we're running into the same thing with some of the other immune therapies you're talking about. If you have to develop an immune therapy that is unique to that patient in the laboratory, whether it's manipulating their T cells or bispecific manipulation of antibodies and so forth, and it's unique to that patient, then it's very expensive. So everybody's trying to hope that there's some off-the-shelf approaches that can be used for cellular immunity. And we can talk about the PD-1 inhibitors and so forth if you'd like.
There is also the issue of the cost for spilocell.
Yeah.
Cost is
and I think the cost has been something challenging for all of us in terms of, is a 4 or 5 month, 6 month, whatever it is, improvement in survival worth $100,000, which is what it costs in the United States for a treatment.